Hi, this is Johnny Rose, Assistant Professor in the Department of Family Medicine and Community Health, and I've been asked to talk to you today about insurance. As you go into your career, it's going to be important to understand these things, not only because of the business aspects, but in order to advocate for your patients. So this is a generic model for how healthcare gets paid for. It's kind of a triangle. It starts with the patient, of course, who sees the provider, but often there's a third party involved, the payer, and this can be an insurance company or a government entity. And there's money that the patient pays on a regular basis to the payer. The payer then, when the patient sees their provider, reimburses the provider or sometimes pays them ahead of time. We'll talk about that later. And there is some cost sharing wherein the patient pays the provider every time they go to access care. So why do we need health insurance? Why have these third parties? Healthcare costs can be really extreme. If you look at this graph, you'll see that 50% of healthcare costs in the U.S. are attributable to only about 5% of patients. So if you're in that 5%, you really need some sort of protection financially in order to ensure access to care. And really this is how insurance actually got started. Providers need a way to get paid. Essentially the way it works is that you have a small number of people who get out of the system much more than they pay in, and everyone else essentially subsidizes them. But everyone gets the peace of mind, the financial protection, and in theory the access to care. So this is the idea of spreading out the risk. Looking again at our payment model, there are pretty much 4 different versions of this. In any health system around the world, including the U.S., there are pretty much 4 ways that care gets paid for. The first is really simple, the out-of-pocket model. People just pay directly for their care. You see it a lot in the developing world, and you see it a lot in the United States. Obviously, there are disadvantages to this if you're unable to afford your care. Second is the national health insurance model, or a single-payer model. This is where you have a single government payer. You have a system of mostly private insurers and facilities. This is a lot like the Canadian system. We also have a national health insurance system in the U.S. at the federal level called Medicare, which is how people over 65 get their insurance coverage for the most part, as well as a lot of people with disabilities. And then at the state level, we have Medicaid plans that are these sort of state-level single-payer plan. The third model is the socialized model. And this is where you have not only the government paying, but also you have the government actually owning the facilities, employing the provider. Now, you may not think that we have socialized healthcare here in the U.S., but a significant part of our system is socialized. The VA, military, Indian Health Service, safety net providers. Think of Metro Health. Most big cities have something like this. It's a county-run hospital. Fourth, and the focus of what we're going to talk about today, is the private insurance model. So here you have companies that are mostly private, for-profit companies that act as these third parties. This is the biggest portion of the market. This is how the greatest chunk of people in the United States get their health care paid for. Okay, and so here we're going to have a patient paying what are called premiums to the health insurance company, and when they go to seek care, there's some level of cost sharing, and the provider gets reimbursed from the insurance company. So let's get familiar with some basic health insurance concepts. First, premiums. This is what the insured person pays on a regular basis to the insurance company. This is usually a monthly payment. A deductible. So this is just a threshold amount that the insured person has to pay for themselves before their insurance kicks in. We'll look at an example of that here in a second. Finally, there's this idea of cost sharing at the point of care. It's a way theoretically that helps put some of the patient's own skin in the game, if you will. It's thought to discourage unnecessary utilization and to help keep premiums lower. There's some debate about the extent to which it actually does discourage unnecessary utilization and whether the utilization it discourages is actually unnecessary, but that's for another lecture. A co-payment is a common way that there'll be cost sharing when someone goes to see their provider. It's just a flat amount like $20 or $40 that you pay when you come to see your provider. Also, there's something known as co-insurance, which is actually becoming more and more common these days. It's a percent of the full cost that must be paid by the patient when they go to seek care. So, for instance, 20%. You pay 20% of the bill, your insurer pays 80%. There is an out-of-pocket maximum, which is sort of a safety valve. It's a threshold where your cost sharing goes to zero. So in other words, your co-insurance becomes 0% above some certain level. And that's just to prevent, catastrophic costs in the event that you have to have extensive care. Let's look at a scenario. Jack is a med student with insurance that has a $500 annual deductible and 10% co-insurance. He presents to the ED after breaking his arm and incurs charges of $1,000 for the care he receives before being discharged home. How much must he pay out of pocket if this is the first time he sought care this year? And the answer would be $550. Since this is the first time he sought care this year, he has to meet his $500 deductible before any benefits kick in. So he pays the first $500, there's $500 left to pay, of which he has to pay 10%. So he has to pay $550. If he then breaks his arm again the next month, or any time in the rest of the year, he goes in, if he gets $1,000 in charges, he would only have to pay $100. Because since he's met his deductible, the insurance is going to cover 90% of that entire $1,000.